Good afternoon, everybody. Welcome and thank you for joining us today. This is the final event in our 2022 Institute for Implementation Science seminar series. Recordings for past events can be found on our website, which we'll put in the chat shortly. Just a few quick announcements. This panel is being recorded, and the recording will be posted on our website after the event. All microphones are muted, so if you have any questions or comments, please put them in the Q&A box, as there will be time for discussion and questions after the panel presentations. Now, our Institute co-director, Dr. Balasubramanian, will introduce today's panelists. Thank you.
Thank you, Ricky. I'm so thrilled to introduce three phenomenal speakers and researchers for our Implementation Science and Health Equity panel. For the next hour and a half to perhaps 2 hours. The way we've organized this panel is that all three of our speakers will provide about 20 minutes or so of comments and presentation, followed by question and answers from the audience. So we encourage you to please add your questions into the chat box and we'll feed them at the end. But without further ado, I want to first introduce our speakers, beginning with Dr. Maria Fernandez. She's the Professor of Health Promotion and Behavioral Sciences and Director for the Center for Health Promotion and Prevention Research at our UTHealth Houston School of Public Health. She's also the Director of CDC's Texas Prevention Research Center and founding co-director with me of the new UTHealth Institute for Implementation Science. Her research focuses on cancer and chronic disease prevention and control among underserved populations in the US and globally. And she has extensive expertise in research translation and D&I research. As both a researcher and a leader, Dr. Fernandez has spent her career conducting participatory, community-engaged research and practice to develop, evaluate, implement, and disseminate interventions to improve health equity. She was recently awarded the Association of Schools and Programs of Public Health Research Excellence Award and the UTHealth President's Scholar Award for Research Excellence. Joining Dr. Fernandez is Dr. Anna Baumann, who is an assistant professor of surgery at the Washington University School of Medicine. Her research involves reducing racial and ethnic disparities in access and utilization of services to treatment and quality of care. She does this by working on strategies for adapting, implementing, and disseminating evidence-based interventions for ethnic minority populations. She's a co-director of the Dissemination and Implementation Research Core, which is a methods core at the Institute of Clinical and Translational Sciences, and it provides methodologic expertise to advance translational research to inform and move efficacious practices from clinical knowledge to routine care. Through DIRC, she has supported many investigators in receiving federally funded studies aiming to accelerate the use of evidence-based interventions in different settings of care. Finally, Dr. Adsul, Dr. Prajakta Adsul is an assistant professor in the Department of Internal Medicine at the University of New Mexico and a member in the University of New Mexico's Comprehensive Cancer Center. Dr. Adsul's research uses implementation science theories, methods, and measures, keeping a multi-level perspective. Her research utilizes qualitative, quantitative, and mixed methods to incorporate the complexities of real-world practice and produce meaningful and useful products relevant to several stakeholders. Dr. Adsul's current portfolio is focusing on understanding the implementation of cancer screening services in low-resource primary care settings and among underserved and diverse populations, with an emphasis on follow-up for individuals. She currently has projects in Latin America, India, and New Mexico that study the implementation context of cervical and colorectal cancer screening to improve population-level outcomes. I am so thrilled to welcome you all. And with that, I will hand it over to Dr. Fernandez to kick it off for us here.
Thank you so much, Adsul, for those introductions. I'm going to share my screen. You can just let me know you can see it okay.
Looks great.
Great. Right. Well, hello, everyone. It's a pleasure to be here, and particularly with these two phenomenal scholars in the area of implementation science and health equity. Don't let the assistant in front of their assistant professor title fool you. These are folks with a tremendous amount of experience and insight into this important area. My role is to give a little bit of background and set the stage for our discussion today. I'm going to start with some definitions and just a little bit about the role of implementation science in improving health equity. I want to make a point about the importance of learning from other disciplines. We started to do that in this space, but I think we can do much more of that. And importantly, in the area of engagement, community based participatory research, implementation research and practice partnerships are critical for improving equity. And I'm going to briefly talk about that and give a quick example. So first, by way of definitions, we know that health disparities, which is perhaps a term that we've used in the past, and now we're using health equity, and there's slightly different connotations. But when we talk about health disparities, we mean the disproportionate burden of disease, disability, or premature death experienced by specific groups. And while many times people are talking about ethnic groups, ethnic and racial groups, they can be any groups defined by geography, gender, age, sexual orientation, socioeconomic status, and others. So health equity then is the attainment of the highest level of health possible for all people. And achieving health equity requires that we value everyone and that there's a focus on ongoing societal efforts. I think I was going to talk about how we never quite get there. It has to be something that is ongoing. And these efforts have to be coordinated to avoid inequalities, address historical and contemporary injustices, and eliminate health disparities and healthcare disparities in particular. So when we talk about health inequity, then we're talking about these differences in health status between more or less socially and economically advantaged groups. And the difference perhaps between when we talk about health inequity and health disparities is that when we talk about inequities, we're making the assumption that these are caused by systemic differences in social conditions and processes, and that they are avoidable, unjust, and therefore they're actionable. We're going to talk a little bit more about structural inequities, but I wanted to provide a definition here and mention it because when we think about implementation and implementation science, much of what contributes to the determining whether innovations that could make an impact on health are equitably adopted, implemented, and maintained. The structural inequities that exist create substantial barriers in this regard. So they can include things such as finance, housing, transportation, education, social opportunities that are structured in ways that benefit one population unfairly. And this is true whether it's intended or not. I think that this is a misconception that some people have, that when we talk about inequities, that there's sort of intention behind it. And it is certainly possible that there is, but it's also possible that structural inequities exist without, even when they're not intentional. But essentially, it's a system of privilege and inequality that's created and maintained by interlocking societal institutions. And since it's typically embedded within and across institutions, and that these are interconnected, oftentimes they work to support and maintain one another, and therefore support and maintain inequities that exist. So what's the goal? The goal is achieving health equity and eliminating health disparities, but it requires everyone making intentional and consistent efforts to address these inequities. I really like this picture because it's drawing, because many people sort of understand what's in these first two panels, right? The difference between equality and equity, and that it's not enough to give everyone the same thing, that because not everyone has the same circumstances, that we need to do different things for different people to achieve equality. But this last panel represents a world where there are no barriers. And this, I think, is where we strive when we think about true equity. When we think about the research and practice that can lead towards improving health equity, we can think about it in ways of understanding or answering questions about detecting, understanding, intervening, and then finally, with the focus today, implementing. In detecting, we're answering the question of, do disparities exist or inequities exist? We try to understand why do these disparities and inequities exist, and then we intervene. For many years, when I heard, I was fascinated with this idea of social disparity and social determinants of health, but I was frustrated by the continued discussion about social determinants without about, okay, what do we do about it? And I think that the various fields have moved to developing interventions to actually make a difference in terms of health inequities. And now we have to continue to do that, but we also have to address the challenge of how can we best implement and scale up interventions, services, and policies to eliminate health disparities. So the questions around detecting are, what groups experience, what's the extent, are they present, are they changing? Questions around understanding can include things like what behaviors influence health inequities, what environmental influences contribute to them, and what determines influence those. How can we intervene at multiple levels to address health inequities? And then how can we accelerate the adoption, implementation, and maintenance of effective interventions to reduce inequities? So the field of implementation science has now fairly recently embraced health equity as a key focus for advancing the field. And there's been numerous key commentaries published to advance specialization and integration. And a couple of these are from our scholars today. I won't talk too much about this one because I'm just going to focus on it, but I think it provides some key elements, some key points to be thinking about as we're addressing health inequities with implementation science. The field have looked at this in terms of specific topic areas. And Prajakta is an author of this article, which talks about building capacity for health equity and community engagement implementation science, incorporating health equity considerations across all key implementation science areas, and continuing to do transdisciplinary health equity research and implementation science. Frameworks such as the health equity implementation framework have been developed to improve our understanding of the determinants of implementation from a health equity frame. In this framework, it builds upon CPER and similar frameworks by providing discrete constructs that help address some of the structural, interpersonal, and policy-related factors that are heavily linked to creating inequities and maintaining inequities. In health promotion, we have processes and frameworks that consider the multi-level influences in health and recommend doing things like environmental asset mapping. This is a process that we recommend intervention mapping described by my colleague Andrew Springer, which looks at various settings and not only how these settings can contribute to existing inequities, but how can we leverage these settings when we intervene and when we develop and implementation strategies to deliver effective interventions. So a really nice, very recent article that looks at, it talks about taking an interdisciplinary approach to health equity. So I already talked about a couple models that sociology and health promotion and looking at health equity and trying to understand how to improve health equity. And in implementation science, I think we do have a history and of incorporating other disciplines in our work. And I think that we're starting to do that with health equity, but there's a lot more that can be done. In this particular article, they talk about ways to take this interdisciplinary perspective to generate evidence to advance health equity, and to do so in a way taking a theoretically critical approach to our own field. The application of critical theories is necessary to further health equity and shaping policy and systems assets as well as health interventions. They also point out that structural inequality, power, and flexibility need to be evaluated by critical theoretic foundations in order to increase the capacity of our field to move forward in this area. And so I'm just going to highlight a couple of the approaches and the theoretical perspectives that they recommend, because I think it's really interesting, and it's related to some of the things that Prajakta is going to talk about here. One is post-coloniality and reflexivity, so reconsidering evidence and engagement. Key partners who facilitate implementation, like research teams, have social positions that shape our interpretation of intervention outcomes. And this includes things like what outcomes we'll measure and what we won't measure, what participants are included and not included. Health development and health intervention development often emphasize solutions that ignore the historical context of colonialism and continued domestic and global inequalities. Post-colonial theory, for example, emphasizes how the production of scientific knowledge and historical knowledge has been the domain of powerful and largely white Western and medical actors. And by utilizing and thinking about this type of theory, these types of theories and frameworks, implementation research has the potential to weave these concepts in, and using community participation, which I'll talk about in a minute, and employing practices or reflexivity, this can help advance how we're doing our work, how we're doing our research, how we're doing the practice, how we're developing our implementation strategies. Another sort of category of theories are those that represent are about structural violence, intersectionality, and related theories. Right? And adaptation efforts, which I know Anna's going to talk about, often neglect conceptual frameworks that explicitly account for those factors that contribute to health inequities. And the practice ignores influences about how interventions are received by communities, especially within groups that have been socially marginalized. And so thinking about this intersectionality and related theories can help us avoid these pitfalls as we move towards improving our approaches to implementation science and improving health equity. And then this one is one that's, I think, a little bit more, we've thought about this a little bit already in our field, theories of policy and doctrine. Part of that is because we know that in implementation science, that context is everything, right? That's sort of the catchphrase in implementation science field, context is everything. And so external contextual factors, we know are multiple frameworks in implementation science that They help shape the development of strategies to advance. In anthropology, and many of these concepts come, I forgot to mention that, from anthropology and also sociology. Anthropologists have advised studying institutional practices as culture, and in fact, we do think about that in many of our measures when we're measuring institutional culture and how that influences organization. And theories of governance also consider how policy influences services and organization, and this can offer information. So I just wanted to highlight some of the very excellent points in this article that I mentioned slides ago, but I encourage you to get it because I think it can help us think about unique ways that we can advance our field in this regard. Another recent article that talks about dissemination of to advance health equity, specifically about systems, I think does a really nice job of kind of summarizing some of the recent frameworks and arguments. But they make the point that despite the growth of the literature resources in the last few years, that there's still a lack of guidance for researchers on equitable dissemination populations who are the recipients of our evidence-based intervention. And they present a couple of examples within this article about how the researchers engage the populations to make sure that they were creating systematic change. I debated whether or not to talk about this, but what is now being known as health equity tourism. Health equity tourism has been highlighted, and there's been some articles in the popular literature as well, not just scientific work, to talk about this idea that racial inequities in the United States have been around for centuries, and because there is additional attention and perhaps resources now that many more scholars are getting into this area of equity. And while initially you might think that's great, the more people that are addressing this problem, the better. It's a big problem. That's why best approaches to address this. There's also been this concern that for scholars who really have, this has never really been an area of them, or in fact even an interest, that in fact it could be recapitulating systems of inequity within the academy and create a dilution of this landscape that are carefully curated by scholars who demonstrate in this equity research. And so in this article, they provide some principles that can guide novice equity researchers to become community members rather than encourage health equity. And when I was creating the bullets for this slide, I wanted to actually use the words of these authors because I think that they articulate well. I would love to have part of our discussion talking about this because I do think that there's this sort of tension between being careful about ensuring that this isn't just another topic area where there's money. Those who always get the grants and get the resources are now doing this, and that could be taken away from the resources for people who have been steeped for years in the study and are perhaps because they belong to marginalized groups themselves, or because they've been working in these spaces for many years, are precisely the ones who should be benefiting from these resources. So I think it's a really important topic, but I also think it's a very nuanced topic because we certainly don't want to take away from the energy and commitment, and sometimes it can be new commitment of researchers that are interested in. So really curious for your thoughts and ideas on this topic.
Maria, this is Vijay. I'm sorry to interrupt you. Your audio is a little choppy. Perhaps just speaking louder or closer to the mic might help the audio quality. We had a couple people who mentioned that in this Q&A.
Yeah, thank you for pointing that out. I just moved my computer a little bit closer, so hopefully that's better. Sorry about that, folks.
Thanks.
So one of the ways that, and certainly not the only way, you know, we're that both Anna and Prajakta are going to talk about many other perspectives, but certainly one of the ways that we can help to improve health equity within implementation science is incorporation of community-based participatory research principles. And I won't read this definition. Many of you are very familiar with CVPR and engagement research. And while they're not analogous, right? CVPR has very specific sort of guidelines and underpinnings. When we talk about engagement more broadly, we talk about the process of working collaboratively and through groups of people who are affiliated, and it may be through geographic proximity or similar interests. And it's a process through which community members are empowered to create change. When we talk about community engagement from the perspective of implementation science, we're typically talking about engagement across multiple levels of influence. So community members, absolutely, but also those who are making decisions at the various stages of implementation. So decisions about adoption, decisions that can influence and impact implementation, and also for sustainment and scale up and spread. And so engagement of individuals or actors that have control of the various processes in implementation is critical. Unfortunately, dissemination and implementation science and community engagement have developed along parallel tracks. However, they're like equity, there's increased interest in the integration of community engagement and D&I fields, processes, and frameworks. There's a really nice narrative review that identified 5 community engagement constructs that are critical and particularly relevant in implementation science. And these include things like community communication, partnership exchange, community capacity building, leadership, and collaboration. So using CVPR and community engagement approaches can help in a number of ways. It can help in developing interventions that are more likely to be used because they're more appealing, relevant, feasible. Anna's going to talk a little bit about this and when she talks about starting at the beginning when thinking about equity and inclusion. Engaging communities as partners in all phases maximizes sustainability, reach, adoption, and effectiveness. And it also allows for modeling, right? When actors within the community have been successful at adopting and implementing, they tend to influence others in doing the same. Certainly adaptation of interventions, and Anna's going to talk more about that, with cultural and local context enhances relevance, effectiveness, and community ownership. And then strategic partnerships. And this is, I'm going to give you an example of one of the ways that we've used strategic partnerships for reaching those most in need. So many of you may be familiar with the 211 helpline, but in case you aren't, it's a nationally designated 3-digit telephone number for information referrals to social services. It's provided by more than 200 local organizations that are committed to serving their communities, for example, the United Way, but also Goodwill and community action partnerships and local crisis centers implement the 211 program.
Last year in 2021, the 211 network answered more than 19.7 million phone calls and responded to more than 1.4 million texts. And so there's there's millions and millions of total connections that help people in a number of different ways. And these include things like basic needs, healthcare, senior services, etc. One of the things that I think makes 211 the most successful is that it's people talking to people. So here's an organization with tremendous reach, reaching people who are most in need because they are responding to calls for help on many of these issues, which essentially are those social determinants of health. And how can we partner with an organization like this to improve health equity? So about 10 years ago, the National Cancer Institute's Behavioral Research Program in the Division of Cancer Control and Population Sciences and the Office of Behavioral and Social Science Research sponsored this supplement that on collaborations with 211. And it was put together through the Health Research Working Group. And the goals were sort of to raise awareness and opportunities and benefits of engaging with 211 research collaborations and to share some successes in doing so. The Cancer Prevention Control Research Network, which I'll mention in a minute, took this challenge and collaborated with 211 on a number of different initiatives, and I'll give you an example of one of them. But before that, I wanted to point out how consistent with one of the most widely used frameworks in implementation science, the AIM model, the collaboration with 211 is so impactful because it reaches this population. And in our case, an example I'm going to give you is with cancer prevention and control. It reaches folks that are in great need of these services. So the CPCRN collaborated with several sites across the country to determine the feasibility of assessing cancer control needs and providing referrals across 211 call centers. And what was clear from this study was that there are individuals that were calling 211 for anything, not necessarily for health, definitely not for cancer control, but that they were calling, those folks that were calling were in need of cancer control services. So there is a much higher proportion of people who are uninsured, lower rates of screening, use of cessation services. And the studies also demonstrated the feasibility of intervening in 211. In Texas, through funding from our Cancer Prevention Research Institute of Texas, and also from National Cancer Institute funding, we worked with 3 211 call centers across the country to implement an intervention. And this was a study to assess whether just providing a referral, assessing what they needed, and then providing the referral for cancer control would be effective. And we were comparing it to the use of navigation. And so what we found was that they both were effective. And because they were reaching large numbers of individuals, the impact had and could potentially have a great population health impact. There's also been other projects that have worked with other topic areas. For example, Emory worked on smoke-free homes. We did efficacy trials and effectiveness trials, replication trials, and then a national dissemination of smoke-free homes, which I think is a really excellent example of leveraging this partnership, a partnership that has tremendous reach to make an impact on accelerating and improving the adoption and implementation and scale up of evidence-based practices and programs. There was also Emily also worked with Healthy Homes, Healthy Families Project to adapt an effective home food environment intervention for 211 and conducted a pilot study, and then a hybrid effectiveness implementation trial. In the interest of time, I won't go into details about this, but just wanted to provide you an example of how we've leveraged these partnerships. Now, was it automatic? No. We had to develop strategies to improve the adoption, implementation, and maintenance of these interventions. In this article, we talk about how we use implementation mapping to develop these strategies so that navigators that are usually providing referral services were now doing a little bit more in assessing needs and connecting people with navigators. With COVID-19, 211 was a tremendous and important partner in serving as a resource and COVID-19 helpline. Just in this time period from March to June, there were over 100,000 calls specifically related to 211, where people were asking for various types of assistance. We looked at, in a study that was funded by the RADx project, Rapid Access for Diagnostics for Underserved Populations, we looked at the relationships between various organizations, including the Harris County Public Health, our local health department, and 211, and many other organizations, and looked at how they were connected in terms of offering services and help related to COVID-19. And this was really important because it identified 211 as a major resource and as a connector for people to many other different types of services. We use this information as well as other information that helped us identify specific areas within the community, within this broader or the county, that were experiencing inequities. And we use this information to help intervene. And 211, this is actually an ongoing project that we're doing right now, identifying callers that are coming from these communities and intervening through 211 through a process that's similar to the one that we did with cancer, but now focusing on improving COVID-19 vaccination and testing when necessary. So I just wanted to provide that example, but also mention that it's not without its challenges. We're doing scientific research in a service-oriented environment, but because this research and this program is consistent with the values and norms of the organization, it readily accepted and encouraged within that organization. I want to close by just making a comment, I know that we use this term, and I don't think that there's anything wrong with the term of having an equity lens, and I'm sure you'll hear it from probably both Prajakta and Anna. But I wanted to just reflect on the term for a minute and perhaps think about how we want to move out from behind this lens of looking at this problem of health equity to becoming participants, to engaging communities, as I talked about before, communities across various levels of influence in order to address this problem. So we know that when we're looking through a lens, the lens can be distorted. It's often distorted through our own positionality, through our own perspectives. And I think that it also can be distorted through our own discipline. And therefore, the topics that I mentioned, learning from other disciplines, and also engaging partners throughout the process, I think is one way that we can ensure that we're moving forward in this field of implementation science and health equity. So I'll stop there, and I think that we're going to take questions and discussions at the end, but certainly if you have questions or comments, please put them in the chat and we'll talk about them afterwards. Thanks, everybody.
Thank you, Maria. This was fantastic. I think I'm next, right? I'm just to make sure that I'm not.
Yes, that's correct.
I want to say thank you, and I appreciate the introduction and a lot of information for us to think about. So the title of my talk is about equity is not a checklist. If there's anything that you get out of the next set of slides is that there are many paths that you can think about when you talk about equity. Checklist, meaning I've done X and I have achieved equity, is not one of them. So let's think about what might that look like. I do want to disclose that those slides that I have audited for visual disabilities, I have not been asked to audit them. So I do want us to sit in our privilege in thinking about who is present in the webinar today, but also who is absent and why. If you need an audited version, I'm happy to audit them. If you do not know what that means, just Google and email me. I am a research faculty, so I have the honor to hang out. It's my opinion and not of my funders. You will see in the bottom of my slides, my Twitter handle. It is self-promotion, but it is self-promotion mainly because a number of us are still in the Twitter space, and several of us are doing advocacy work in the context of implementation science and equity using those handles. So I often post resources and networks and talks about this topic. Sorry, I'm still trying to recover from the flu, and apparently I'm still coughing. So we're gonna have some extra sound bites, but we're gonna be okay, I hope. So that's the Twitter, and those are the reasons. Maria mentioned about the positionality, and to me, it's really important to share where I am coming from when we talk about equity. In terms of demographic markers, I am I was born and raised in Brazil. Sorry. Hence, I'm dual citizen. I am able-bodied, white-skinned, colonizer, mother, cisgender, scholar woman. In terms of my own work, I do a lot of work in the context of parent interventions and other interventions in different settings in the US, globally, a lot of work for Latino communities, but more recently with other communities. In terms of theory, the theories that inform our work are implementation science, cultural adaptation science, health equity, and the more that I study around how to think about equity and implementation science, other theories and other bodies of literature. So this is who I am as of today, and those are the lenses that affect the way that I conceptualize and think about my research questions and the conversations around equity, which might or may not be the same as they are for you or for somebody else. In the field of D&I, we tend to blend the D with the I, D meaning dissemination. I do want to say that dissemination is a whole different thing. We've talked about this, we've published about this. Several people are talking about dissemination. Today, we're going to talk about implementation science. Dissemination science is a whole nother conversation, which I'm also happy to talk about. So when I think about equity and implementation science, I love to ask people, what does equity look like for you as a person? What does equity look like for you in terms of your research agenda? If you feel brave, you can put it in the chat so we can have that conversation. And I say that because there are many ways and routes that you can think about equity and that intersection in implementation science. You can think about methods, you can think about measures, designs, and today we're talking a lot about frameworks, about studies in a very global way, right? Maria talked a lot about her study, but Prajakta and I are going to talk about a lot more in terms of reflection in terms of your work. When we talk about equity, to me, it's also important to highlight what is not equity so we can set up some boundaries. Equity is not an outcome. You don't achieve. It's not an, if I've done X, I have reached equity. It's definitely not a checklist. It's not diversity. The fact that you have different types of participants in your study or in your research team does not necessarily mean that you have achieved equity. It is certainly not a scarcity perspective, meaning if you work with one community in one setting, other communities will not have the same resources. So this is one of the figures that I love to talk about because it talks about the different flavors of equity. Inequality is you have a setting A, community A, that has a lot more resources than community B. That's the current state of art, right? Equality is you giving the same intervention or the same implementation strategy to different contexts, regardless of how they are. Equity might be you adapting the intervention or the strategy depending on the context. But hopefully, in a couple of years, we can talk about justice and implementation science, meaning how can we address the root causes of inequality and really think about how can each one of us, regardless of the context, can have the best well-being opportunities for for our health, for our mental health, for our happiness. So I mentioned that there are many ways that we can talk about equity. Today's focus on my talk is on frameworks. And so I ask you, why are frameworks important? And I hope that your answer says, well, frameworks are important because they affect the way that we conceptualize our questions, our designs, our measures, the way that we think about our work. Originally, in the field of the D&I, we didn't have explicit equity-focused constructs in our frameworks. Why is that a problem? That is a problem because a colorblind way of thinking in terms of methods, in terms of research, in terms of acting in the world, we know perpetrate inequalities. So several of us have then been putting forth frameworks to help us conceptualize what an equity D&I space might look like. This is a host of frameworks. There are already missing frameworks because thankfully several of us are working on that space. So you have that for you as a resource. We're going to talk about one of them. It's just one perspective that Leo and I put forth in thinking about not necessarily developing yet another framework, but how we can capture one of the frameworks that are classic in the field of implementation science and think about how we can layer and implement an equity lens on that framework. With the idea that then that will help reduce inequities in healthcare. One of the things that Leo and I wrote in that paper is the importance of assumptions. So he and I come from the field of cultural adaptation, which is a field in the context of mental health that was born in thinking about all the randomized control trials in the context of developing and testing interventions in the mental health field were done with white populations. So there's a whole field that put forth methods and frameworks to adapt those interventions for historically marginalized population. The assumption there was that you had to adapt the interventions by adding cultural values and assets in those interventions. But then the problem is that those interventions are not being implemented in usual care. There's this whole other field, and Maria mentioned about the healthcare disparities field, which was born to identify the disparities in healthcare and to develop and test interventions to decrease those disparities. The problem is that those interventions are also not being implemented in usual care. And then there's us, the implementation scientists, the field that was born to decrease the quality gap by implementing evidence-based interventions in usual care. That's the definition, right? The problem is the missing in that intervention, in that definition, is the assumption that if the fact that I implement an intervention without thinking about the context does not necessarily decrease inequities or disparities. So what does that mean? It means that we need to think about, when you select your frameworks, your theories, your research questions, we ask you to think about what are the assumptions on those frameworks, designs, theories that are implicit and explicit as it relates to equity. Ask yourself. I promise you, there's going to be racism bias. So ask, how are they centering your research design? How can you address them? What is the historical context of racial oppression as it relates to your topic of research? How are you testing or implementing interventions in a fairly or equitable way? How are you recognizing the historical context of your organization as you do your work? Because implementation is a political aspect. And when we say, I have this evidence-based intervention that needs to be implemented in usual care, without really conceptualizing the context, that can be colonialism. And that can be imposing power and actually potentially imposing harm. So if you've been around in the field of implementation science, I hope that you've seen this framework. That's another Proctor's framework that talks about the what is intervention that you're developing or testing, the how are you implementing this? So say a parent intervention, and you implement it by providing supervisions to providers, to therapists, workshops. That relationship is affected by implementation outcomes. Is this an intervention that is feasible? Do providers like it? Is it costly? Service outcomes in the context of emergency department, for example, timeliness is really important. From the moment that you enter the building to the moment that you receive your intervention matters a lot. And all of that affects then your patient outcome. But all of those things are embedded in the context, right? So you might have the best intervention. Pick one, a drug that improves pain. You might know how to train providers to prescribe the drug for whatever disease, for whatever person. It might be feasible in terms of costs. It might be effective because, it decreases the pain in a certain amount of time. But if your patient has to choose between buying the drug or coming to the hospital versus safety in their home or transportation, paying for medication, paying for your visit versus paying for food. If your patient cannot come to the hospital because he or she or they might be deported, if there is no access because of disability or other laws that prevents them to come and receive the best quality care that they deserve, what is the point? So we really need, if we're doing equitable work, to consider context. So Leo and I provided 5 recommendations to do so. One is to think about reach. There's tons of data. You can pick whatever disease it might be, mental health, cancer, whatever types of cancer, it does not matter. There is underrepresentation of historically marginalized communities in clinical trials. The consequence of that is that you have issues with measurement development, with intervention efficacy, and intervention sustainability. Those who need us the most are not present when we need them to develop interventions that are efficacious in terms of equity. So we talk about reach, not only in terms of patients coming or participants in your trials, but thinking about reach also in terms of communities and settings. I would love to see more implementation trials in food banks, in churches, in laundromats. Why are we not reaching the community where the community is? So I ask you to think who is present, in your research, but most importantly, who is absent and why are they absent from your studies? Who is absent in your research team? Who is absent from your own network and why? There's a body of literature trying to think about how we can reach and engage historically marginalized populations. Use of peer-to-peer, people that are part of the community, that they bring trust. Think about issues of safety, of access. Think about using technology. The question is, if you're not being able to engage and recruit participants, the problem is not on the participant. The problem is on us. We need to be creative and meet the people where they are, not ask people to come to us. Then design and select interventions with implementation in mind. We need to think about how we can develop interventions with and for the community, not just develop interventions with some of the people from the community. Again, there are tons of methodology, user-centered design, intervention mapping, laboratories, community participatory research, with attention to developing interventions that are flexible, that can be cost-effective, that can be implemented and sustained in low resource settings for those settings who need us the most. So I ask you, how adaptable is your intervention? How can you ensure that your intervention is going to fit different contexts and reach different populations? Whose voices are informing the development and evaluation of your intervention? And how are you managing issues of power and privilege? Implement what works and develop strategies. Maria mentioned tons of interventions and partnerships that we've seen help decrease disparities. There are out there, they exist. They're complicated, but they do exist. But they're not being implemented in usual care. If you've been in the field of implementation science, you've heard about the ERIC strategies, right? The compilation of list of strategies. Missing in those strategies are equitable focus strategies, strategies that would increase trust, strategies that talk about advocacy, strategies that talk about anti-racism, allyship. So this slide has a very different font because I would love for us from the field of implementation science to learn from our many literature that's out there around how to decrease stigma, how to decrease oppression, how to address anti-racism. Why are we not embedding equity lens in our implementation strategies? This is a paper by Larissa Gaias and collaborators that I think it's really important for us to think about. Because any strategy, pick one educational strategy that we all do, can have an equity focused and improve equity or actually accelerate disparities. So they ask us to really think about what are the underlying assumptions of the strategies, what are the potential sources of disparities, and how can we address disparities as we implement and develop and implement those strategies. Then you have your intervention, you have your strategy. Now the piece is how to adapt. Adaptation happens. This is the slide that goes in every single talk that I give, right? Which makes a lot of sense. We needed data, we have data now. We have tons of data showing that providers adapt. The metaphor that I use is you're not brushing your teeth in the same way, exactly the same way as you do every single day, right? Because we're humans, we adapt. That's part of life. That's a beautiful part of life. We used to say that adaptation is against fidelity. Now we know that that's not true. Not only it's not true, but if you're talking about context around disparities and historically marginalized populations, you have to adapt. That's a whole literature showing meta-analysis, showing data, showing the importance of adaptation. Okay, adaptation happens. Let's embrace it. We've put forth tons of us decision trees to help you guide when you need to adapt and what kind of data needs to inform your adaptation. We've put forth frameworks to help you track what you need to track when you adapt. The piece now that's missing in the field are methodologies to track the adaptations so as to not add more burden to the system. Right, so we've been advocating for the science of adaptation and how can we push this field forward, because it makes a lot of sense. There is a relationship between the intervention, the strategy, and the context, and that dance between the three of them affect the implementation service and client outcomes. And by tracking what are you adapting, how you're adapting, why are you adapting? That's the only way I think we're going to be really able to capture what are the mechanisms of change of the interventions and the strategies and identify what works for whom, how, and when. So I ask you, how are you planning for adaptations? How are you tracking them? Who is informing the adaptations? And why are you giving voices to whoever it is that you're giving voice to? Finally, we advocate for using an equity lens for implementation outcomes. Here's the thing. Again, you might have the best intervention. You might know how to implement that intervention. But if that intervention is too expensive, it might fall flat. When we talk about evidence-based intervention, there is always an infrastructure that goes behind that evidence-based intervention, right? I love the title of that paper, talking about Trojan horse. So a number of us are in the context of parent intervention. We had one fantastic intervention that we took it to different resources, but it was too expensive. It fell flat. So as you develop and as you think about your intervention and your implementation strategies, it's important for us to place acceptability, feasibility, context, and thinking through how flexible that intervention and that strategy can be so it can be implemented in low resource settings and settings where they need us the most. So placing equity at the forefront, thinking about how to conceptualize feasibility, how to conceptualize acceptability, who is measuring what, who is giving the voice for those outcomes in your study. Because one of the things that we haven't done a good job in our field of implementation science, I think, is to really outline what are the potential negative effects of our work. There will be missing people in your trials. There will be a negative effect because that's part of life. How are you tracking those and how are you addressing them? How is your work either observing or addressing systemic racism and discrimination? So I am always a positive person. I try to be positive, and I think there's a lot of power in our community. And I hope that we can achieve inclusion and representation in our trials, that we can rethink about how we're developing and testing interventions, that we can foster the science of adaptation, place equity at the center of our studies, so then we can really invest in achieving equity in our healthcare. And that's Thank you.
Thanks so much, Anna. And just a reminder, if anybody has any questions, you can put them in the question and answer.
It's a tough act to follow, Maria and Anna, but I'm going to try my best. Ricky, you see my slides?
Yes, looks great.
Good. Okay, really tough act, but I'm so glad that Maria helped lay the groundwork and show through an example, actually, how we can think about equity in implementation science. Anna's amazing, walkthrough of all of the aspects in which we could start thinking about equity more deeply. I'm actually going to talk a little bit more deeply on anti-racism and how we've been able to, with a group of my colleagues, really push this agenda of thinking about racism in implementation science. But before I get started, I wanted to talk a little bit about my positionality. Many of my worldviews are actually shaped by my experiences growing up as a Dalit in India. It is the untouchable category in the Indian caste system. And living there as a young adult and practicing medicine in these communities really opened my eyes to a very different world than what I had grown up as a young person in. My work approaches equity from both global and local spaces. I truly believe that we can learn so much, and I truly believe in that bi-directional exchange. There is so much to learn from resource-limited settings globally, as well as in our own backyards. And today I'm a recent citizen of the US, and I'm a faculty at a wonderful research institution. And my work and my home both rest on the lands of the Pueblos of Sandia. And I'm so honored and grateful to be working in relation to these communities and growing in my understanding of equity and my commitment to not just talk about equity, but to actually practice it within all spaces that I, as a researcher, we as a research institution, and we as a broader research community can practice and include in our work. So with that, I wanted to, both Maria and Anna showed you variations of this picture. I really like this new edition by the Robert Wood Johnson Foundation that really grounds and showcases a little more around the barriers and the circumstances and conditions that are influencing what people need, what people get, and what people need to succeed in their health pursuits, right? And that's where my grounding in equity is how are we doing, what are we doing better to understand and address these barriers, these circumstances and conditions, both through intervention and implementation science. And we continue, even before the COVID-19 pandemic and after the COVID-19 pandemic, we continue to see racially and ethnically minoritized populations experience these inequities. Black patients are less likely to receive certain cancer treatments compared to white patients. Black and Hispanic patients are less likely to access treatments. And this was actually shown by Anderson and colleagues, both prior to and after the pandemic, in which it worsened after the pandemic. And there are members of the racial and ethnic minority groups who have had higher rates of COVID-19 positivity and disease severity than white populations during the COVID-19 pandemic. And what are the causes of these inequities? These are complex, these are multi-level, and they're rooted in the social determinants of health, with a recent focus really going on to structural and political determinants of health. It still is this big system that actually Maria introduced earlier, in which health is just one piece of the puzzle, right? And despite this growing focus on the determinants of health, the role of racism that shapes how these are inequitably distributed amongst the populations, it remains understudied, undocumented, unexplored, and might I say, not explicitly focused on, right? And so we haven't quite gone from race to actually thinking about racism. And how deep is racism, right? It's foundational to our nation's history and the history of the world. In Americas, the extermination of Native Americans, the enslavement of Africans. In India, the caste system. In China, the mistreatment of Uyghur Muslims. This just goes on and on, the list goes on. So we are really entrenched in some of these histories and ongoing systemic influences of racism in our everyday societies and structures. And how far have we come? I was able to do a little bit of a history take on this. And one of the first meetings actually in 1991, and Chandra Ford talks about it in her book In Racism, was this historical gathering at the CDC, which was titled, Is It Race or Racism? And since then, we've seen the ups and downs in the political environment, whether we want to even say the word racism. So public health professionals have been working on this for decades. Social scientists have been challenging this idea of biological essentialism, the notion that race is a biological entity and not a social entity, since even before this meeting. And then there is histories in several other disciplines like anthropology and psychology, fantastic paper by Snellrud and colleagues that Maria talked us through, where these discussions have been ongoing for decades and decades and have a much more deeper understanding around racism. Even a couple decades later, we continue to fight the fight, but much of our research is really focused on still race rather than the racism aspects. It's most focused on discrimination at an interpersonal level, some thinking at the institutional level, some thinking at the multi-level. It's really grounded in that cultural racism that emanates from stereotypes and emanates from perceived norms around subpopulations that facilitates these biases in healthcare and creates unequal health outcomes. It's still focused on community deficits rather than community assets. And how can we really move the needle forward in addressing this? First, we really need to begin with what racism is, right? So Bailey and Ruskin, folks that have been studying this for a long time, have talked about it as a hierarchical system of oppression that works across multiple levels to create, to reinforce, and to maintain inequities. Camera Phyllis Jones talks about racism as a system level, but not an individual level flaw. I love this book by Heather McGee, who says, racism costs everyone. It is the common denominator of most of our social and global realities. And then from the book on racism, in the foreword, again, Camera Phyllis Jones speaks about racism that manifests on several levels, but encourages all of us to pay attention to dismantling structural racism, which is the key to moving forward. In terms of such structural racism, we've been seeing a really huge growth of literature in this space, making progress in thinking about how structural racism operates in the totality of ways and gets fostered by the society through mutually reinforcing systems. These patterns and practices in turn reinforce discriminatory beliefs, values, and distribution of resources. So we are truly moving, like Chandra says, our paths have grown, like Camera says, our paths have gone from race, racism, anti-racism to social justice. So where do we begin in thinking about addressing racism in our own work? And I wanted to present to you 3 specific directions that we can borrow from in the field of disparities work from scholars around critical race theory since the 1980s that have been talking about these and addressing these issues, right? So the critical race theory is one of them, which was recently in 2010 integrated into the public health professional workforce through the public health critical race praxis. It moves beyond us merely documenting health inequities towards understanding and challenging power hierarchies. It helps health researchers carry out equity research with fidelity to CRT. And it's really grounded in race consciousness, but has 4 focus areas of work that needs to be done. One is recognizing racialization and how race is a social construct. The second is thinking about knowledge production and how socially we produce knowledge And a lot of literature right now is coming out in co-production. Third is the conceptualization and measurement, like Anna gave us specific context in implementation outcomes to conceptualize and measure and think through what are we missing. A very important aspect over there is Kimberly Crenshaw's intersectionality framework to think about how do these multiple identities of an individual come together and reinforce and synergize and lead and exacerbate those inequities in so many ways. And then the action orientation in which we examine power, we examine voice, and we examine who is and who is not at the table to promote our work forward. Two other frameworks, anti-racist framework by Bonnet in 2000, he wrote this first edition book in which he really positions anti-racism as a social, scientific, historical, and geographical inquiry. He talks about it being a political force that acts to denaturalize both racial and ethnic allegiances and categories. And he talks about this as both thought and practice to confront and eradicate racism. I've also been very fond of these three short principles that Camera has proposed. Actually, she proposed racism as a public health agenda for APHA, the American Public Health Association. And in that paper, on the bottom right that you see, she says we have to start doing three things. We have to start naming racism. We have to start understanding how racism is operating in your research or research contexts, and organizing and strategizing to act on that. So I hope these are some three or so frameworks that allow you to really ground yourself in some of this deeper thinking that scholars have done before we sort of started thinking about it in the space of implementation science. So for implementation science, why do we think there should be a focus on racism? It is a fundamental aspect of social context, and context, if we know as implementation scientists, is one of the main roles of how implementation science works. And it shapes our institutions, our research, our researchers. There are some advantages and disadvantages in other aspects, right? And then structural racism operates within and across interconnected systems, like I've shown you before, and it shapes both inequities and why there are certain research and practice gaps in certain disease conditions and not in the others, right? And as Anna has encouraged us to think, not considering the role and impact of racism can lead to inaccurate explanations on why inequities exist and suboptimal selection of interventions and strategies to pursue equity. With that, there has been a growing recognition of equity in the field of implementation science. And we were very honored and glad to have participated in the Consortium for Cancer Implementation Science since the last 3-4 years. And we've been really thinking about this space in terms of cancer prevention and control. And we put forward recommendations for both implementation science and health equity research to come together and specifically articulate a focus on health equity in conducting and reviewing implementation science, in models, theories, and frameworks, in methods for understanding and documenting influences on context. And then we realized that if we are to do all of these things, we really have to first start building capacity among our researchers and institutions for a deeper understanding of how equity works, how community engagement works, and how that could influence implementation science. We, like Anna presented, all the key implementation focus areas have to think about adaptations to strategies, to designs, to determinants and outcomes. How do they incorporate equity? And always continue to do this cross-disciplinary talking between equity researchers, disparity researchers, and implementation researchers, because we've got so much to learn from each other. So in the last few years, along with my co-conspirators, I call them my partners, Rachel and April and Derek and Natalie, we've been able to really specifically think about structural racism in the field and how we could start incorporating it within our implementation science research projects and research approaches. So we put forward these 3 recommendations. And the first one really is thinking about structural racism as a part of the determinants framework and thinking about it as a part of the context in how you could start thinking, how you could start incorporating some related measures for racism focused on racial ethnic disparities and health equity within this contextual inquiries, within our theories, within our models that we propose are governing implementation science. We talked about using multi-level approaches for selecting, developing, adapting, and implementing EBIs, because what constitutes evidence, what constitutes evidence-based intervention is a very different answer when you have several partners around the table. And so how do we address the gaps? How do we understand interventions from all perspectives? Therefore, ensuring that they are successful in implementation as well as sustainability. And then I think we cannot do this alone. We really do need transdisciplinary as well as intersectoral collaborations if we are to truly impact and address structural racism in promoting health equity, right? So this is not, I'm very fortunate to have good friends from other disciplines that always remind me that health scientists don't get the adequate social and political training to be able to do this. So I'm very grateful to always have that humbling understanding in my life as a physician turned researcher that I don't quite understand all of it. And I need help from some of these transdisciplinary thought leaders that can help bring clarity to these spaces. We also took a specific approach on anti-racism in this space and really focused in on some core elements of implementation research that could help both the researcher as well as the research context in which we are operating. And we went about it in really thinking through partnership engagement, stakeholder engagement as a foundational basis to engage in implementation research. So there's a lot of action around participatory implementation science. Shobha Ravanathan has written a lot about that and has really emanated from the field of community-based participatory research like Maria presented. Again, theories, models, and frameworks need to incorporate anti-racism frameworks, development, selection, and adaptations of evidence-based interventions, how we evaluate our implementation efforts, and then implementation strategies as well. And I just wanted to, in the next few slides, just give you quick examples that folks have, like all 3 of us have sort of touched on, but wanted to highlight this CBPR conceptual model from Wallerstein and colleagues over here at UNM, who really do consider the context and how the partnership processes work ahead of the intervention research and implementation research that might happen, So that's a really good model that has helped me think about the context as well, especially in community engaged, partnership engaged projects. Anna took a deeper dive in this. Adaptations, we continue to face a reality in which we understand evidence-based interventions, but we don't necessarily have equal representation in these efficacy, effectiveness research portfolios. So that results in a problem with relevance of the intervention, low rates of adoption and sustainability, and might actually also exacerbate disparities. And this part of science really has to bring the information that communities and that partners need forefront, the practitioners need forefront, not what we as academics think are important, right? Like, so when Anna was talking about the adaptome and getting all of this, documenting all of this information, I think we have to be very cognizant on making sure it's the practice-based documentation, not an academic documentation. You all have listened to Laura Damschroeder really take a deeper dive in the CFR framework that has been adapted to use a racism conscious approach, actually through the public health critical race praxis. And it was astounding the way they were able to demonstrate how the leaders' willingness to examine Black and Indigenous students' experience of school discrimination and marginalization impacted several factors related to implementation uptake, right? And how the race and ethnicity of the principals of these schools also influences uptake of the interventions. And so this is the kind of literature we really need to start empirically through our practice-based data generating and discussing and understanding how implementation can be influenced by racism, right? I wanted to highlight this amazing adaptation on intersectionality that has been, I think it was discussed in 2020 D&I conference, and they've just put out this amazing toolkit that allows for a systematic go through of all of these concepts in CFR with keeping an intersectionality lens in mind. Eva Woodward's work in the health equity implementation framework has been really important in bringing the IPARIS framework and really outlining the social context and the social influence and social political forces. And this is where I always keep thinking an exploration on racism, an exploration or understanding anti-racist practices that might be important in this implementation context could fall under this outer circle and could allow for a deeper exploration in your healthcare, in the healthcare institution, in the patient and provider encounters that might happen. We've been in our little group at UNM, we've been trying to really push the agenda on sexual and gender diverse populations. And we truly believe in shifting a paradigm to engage more of the community. Nothing about us without us has been a motto that Mr. Ford, I think, presented to us a few keynotes speeches ago, and that has stuck with me for a long time. And so how do we engage these partners? How do we engage the communities, the individuals, families affected by them, and truly move the paradigm to include both intervention and implementation research, because we need work done in these communities right now. And even as a cisgender heterosexual woman, it has been very important to partner and think through with these communities, what are the next agenda items to bring to the table in terms of cancer prevention and control. So as a summary, as we become clearer in our understanding of implementation science, we must consider the applicability of all of this information for diverse populations and underserved settings. And I hope you took away from all of us today that there are several approaches to engage communities, consider adaptations to context, that are pragmatic and consider complexity through thinking about the whole system at one time. There are methods, and then there are theories, models, and frameworks that can help you explicitly in cooperative focus on equity. With that, I acknowledge all of my funding, but also it takes a village to help me be a speaker today. I have to especially thank all of my colleagues that helped me and let me grow with them in so many of these spaces.
Thanks so much, Prajakta, and thank you again, Anna. I know that Vijay and Ricky have been monitoring the chat and the question and answer. We could start there, but also if you would like to unmute yourself, Ricky, can people unmute themselves if they want to ask a question live?
I can unmute people if you raise your hand. Or if you put a question in the box, I can unmute you directly.
Yeah, so we have a couple questions maybe we can get started with, and I think that will get people thinking a bit more. I will tell you that the presentations are so thought-provoking that I find myself in a very reflective mode. So not having questions up there, I don't think is reflective of in any way about the presentations. It's just so much really, really interesting information that you all have shared, even as an implementation researcher. For me, where I thought I knew a little bit about this, I learned a lot. So thank you. So there is a question about the use of nurse navigators or case managers, and have nurse navigators or case managers been tried to help achieve health equity? And perhaps Anna, you want to go first? You already reacted a little bit to this question.
Yeah, I was just providing an example, and I'm happy to add the site of the paper, which they just did a follow-up with qualitative data, Sarah Birkin's group, getting some more information around, this is in the context, I think, of breast cancer, and they increase rates of screening for breast cancer for comparing Blacks and white patients. So the answer is yes. The challenge is how to sustain, because who pays for it, right? So as anything with equity, it's a multi-level challenge, but there are multiple examples and multiple settings showing the navigators are important. The problem is the sustainability.
And I'll just add, I work really closely with University of Augusta on a project related to sickle cell disease. And as you may know, patients who suffer from sickle cell disease experience not only all of the health challenges associated with that disease, but also often issues related to social determinants of health and racism, absolutely. In their project, they've been using a nurse navigator to help in the continuity of care and increasing referrals and in changing patient behavior and primarily adherence behavior. And it's been really successful. And as we look at, and this speaking to Anna's sort of point about, yes, it works. And we have documentation that it works. Nurse navigators work across multiple settings and diseases. But the challenge is, yes, how do you keep it going? So in this particular project, the research project is paying for the navigator, right? And but then how do we work to sustainability? Sometimes the institution, and in this case, the navigator is embedded within a hospital in another city that where the patients experience a lot of health disparities. And the nurse navigator has become such an indispensable resource for that organization, not only for this particular project, but across many of their patients that aren't enrolled in this particular research study. And so I think that because the value of this person has been established and they're seeing it, that can and will see contribute to sustainability. But an important thing in terms of greater scale up and spread of a model like this, and the nurse navigation is one model. It also includes a sort of a hub and spoke model where people are connected to experts through telemedicine. But the longevity, sustainability, and scale up of this approach is going to depend on our ability to document exactly what the intervention is and its core elements, and then codify and make available those strategies that influence its adoption, implementation, and sustainment, right? So it's not enough to have an intervention that addresses health inequities, but then you have to be able to make sure that it's sustained and that hopefully that it can be scaled up. And that process, that systematic process, is what can be informed by some of the models and frameworks that you've heard about today. Because as we're doing it, we want to absolutely include what we usually do when we think about determinants and using implementation frameworks, but we also want to have these considerations related to racism and inequities that can help ensure that the strategies that we develop are robust enough to withstand and overcome some of those barriers.
Thank you, Maria. And so as I predicted, people are mulling and questions are coming in. So let's go to the next one. How do you think about an approach adaptation for various ethnic groups? For example, people of Latin American origin, similar to other pan-ethnic groups, represent people with very distinct historical, racial, socioeconomic, and cultural traditions. How do we adapt for so many different types of groups? It's a great question. Who wants, Anna?
I can start and then you guys can follow. You ladies can follow. So it's a fantastic question, right? And ideally we would have one intervention for each group. And embedding in the culture and the values, right? I'm from Brazil, and the fact that my neighbor is from Brazil does not mean that we have the same values because she's from the South, I'm not from the South. So even within the country, you would have different things, different values, different foods, different perspectives, right? And then in the context of immigrants, you add the layer of acculturation, etc. So things are complex, right? Language. The way to go about this is, to Maria's point, is to really identify what are the core components of the intervention. And the answer to that question will vary depending on the intervention as well, right? So depending on how complex is the intervention, finding, quote unquote, the core components might take a little while. And that's the importance of developing logic models, of tracking adaptations, of really understanding what it is that you're doing and why and with whom. So then as you implement this intervention with different settings and different populations, you can understand what are the things that you cannot change at all, and what are the things that are more adaptable, and how do you adapt to increase the fit. But it's a fantastic question.
Yeah, I've struggled with this. I've struggled with this throughout my entire career, right? Because sometimes we're funded by the National Institutes of Health to develop an intervention. It's supposed to be broad and supposed to address Hispanics in the United States, right? And then other times we're working in a particular region. And I think that, Anna did a great job of answering that question. And I would just add that while we know that there are differences in histories, traditions, nuance. When you're talking about Spanish speaking, there are really nuances in language. You can usually get around those. There's some exceptions. I can't tell you how many interviews and focus groups we tried to come up with to find a word for wheezing. There were so many different words for wheezing, depending on where you were from. But with some notable exceptions, I think you can generally get around the language issue with Spanish, right? However, there are certain, and Ken Resnicow does a really nice job in talking about deep structure and surface structure adaptation. And many times what we find is that Latino immigrants in the United States are experiencing the same types of structural barriers. And oftentimes even their barriers related to knowledge and attitudes are similar. And so in those cases, those don't have to be adapted, right? You might have to do some modifications for language. But when there's a deep structure difference in terms of something that's like a value, or who within the family makes decisions, or do you defer to for health, those sorts of things, I think that's where you really have to pay attention to making adaptations depending on who you're talking about. But it is a struggle, and I think it's a mistake to assume that you can't have a same or very similar intervention for different groups. We can't possibly create different interventions for every group. And so I think that we have to sort of be careful about that assumption, while at the same time paying attention to those deep structure factors that could actually make a difference in effectiveness.
Yeah, that's great. So
just a couple points.
Yeah,
if I
Prajakta, go.
Two things quickly. One
No.
was, this idea that Maria, you started with, is that there is so much that we have in communities that is common than different. And I can say that from my global and local experiences. So we really need to focus on what is the similarities and how do we build up those assets within whatever community that we are working with, rather than focusing on these racial differences, right? And the second part, I think, is that I really do feel that there is a move in really truly examining intersectionality, because these racial differences, even as they exist, are intersecting with so many other identities that might have more importance for certain populations versus others, right? So for example, in my LGBTQ work, we're recognizing trans folks have issues, like certain challenges and barriers. But when it comes to Black trans folks, there's a whole different layer that we haven't examined. And some of those root causes then, what are they and how do we address them, you know? So I'm advocating more for an intersectionality thinking as well in this space.
That's great. Thank you, Prajakta. And while your mic's open, let's take the question that is addressed to you, but I'm sure others can jump in as well.
And I did like a shameless plug for the D&I talk as well. I was typing the answer out.
Okay, so should I not skip it?
I can just quickly summarize that the question was, how do we generate practice-based data, right? And I think that is very, very important that we don't, redo the 17-year gap for intervention science in a 17-year gap for implementation science, because we do have a lot of terminology. We do have a lot of like, what's an intervention? What's a strategy? I'm not invoking PTSD, Maria, but we do have those discussions a lot as academics. But what do the clinicians and practitioners need is an understanding of what works, what doesn't work in what context, right? So we actually have done some work at the Moonshot Project. Instead of asking them, what strategies did you use? How did you adapt? We just asked them, what did you do? And then we as implementation scientists dissected it and like thought through, what is it that it means? What does this data mean for implementation science? What does this data mean for practice? And we were able to sort of tell them the practice aspects while examine the theoretical and the conceptual aspects as academics in a different space, Not that we didn't engage them, but we brought all of this together. And I think that was really hard work, but I think important as us as implementation scientists to do some of that translational thinking with practitioners, with academics.
That's great. Let's go for one more. This is an interesting one. A lot of evidence-based interventions have information technology-based components delivered using computers and mobile phones. How could your work on equity and implementation science be applied to the field of information technology, health informatics, and artificial intelligence? It's a great question. Maria, you want to take that?
Sure. Yes, the answer is yes. We use this a lot. In fact, and now going back for a really long time, I won't say exactly how long, but in my dissertation work, I worked on developing an interactive intervention for low-income Latinas and on breast and cervical cancer. And one of the ideas was that because these were recent immigrants in the Washington, D.C. area, because many of them were low literacy, then actually a digital intervention would be really useful because there could be visuals and it could be tailored and audio, and it would address some of the barriers in health literacy. So I think that there's a lot of potential for information technology-based interventions. But again, one of the challenges is the delivery. In that project many years ago, these were like kiosks within clinics that people could use when they were just waiting. But there you have one potential disparity is that not everybody is using those clinics, right? And Anna mentioned laundromats and other places, and these are certainly areas where that have high potential. Another thing that I think is really important related to digital health and information technology is that it is widely, even very low income groups have very high usage of smartphones, right? We know this, and that's great because it's an intervention point. I think that there's some differences when we start thinking about the global setting, but at least in the United States, it's pervasive. And the negative part of that is that these groups have been targeted with misinformation. So we have to do a lot of work in terms of trying to understand misinformation and mitigate misinformation, because it can really undo a lot of the good work that is being done in terms of increasing education, increasing access, et cetera. So I think that there's tremendous potential. It is being used, but there's also things that we have to pay attention to and be careful about. Anybody else?
I don't know, Paulina and somebody else asked about the role of technology in interventions. I think there are two pieces here. One is the use of technology to deliver the interventions, so apps, right? So Stephen Schuller comes to mind. He has a center actually in developing apps in the context of mental health. There are a lot of studies in trying to think about how to develop interventions in the context of apps and technology with equity in space. That's one way of using technology. The other way of using technology is the telehealth. And how, especially with COVID, right? Now hospital settings are implementing telehealth, and that poses a whole nother set of issues from HIPAA, from confidentiality, from the types of interventions. Not all interventions are meant to be delivered through technology. And so it's really thinking about, again, because this is the fun part of it, right? What is the goal of the intervention? What kind of intervention are you, or care are you delivering, to whom and how? Yes, a lot of people have phones, but not everybody has, the towers in their rural settings to achieve phone coverage, right? So it's really thinking about what kind of intervention you want to deliver and how can you, within that context and structural context, deliver it.
It's so interesting because what you all both are saying is that technology can be a barrier, but also it can be an opportunity in addressing. So it can be a barrier that contributes to inequities, but also an opportunity to reduce these inequities and achieve health equity. And I think you're right. We need just more creative ways to think about the latter. Where are all those opportunities, and what other disciplines and multi-sectorial partnerships are needed to achieve that? I think there are a couple questions here that are related, I would say, to how do we change people's hearts and minds. So here's one question about oftentimes county hospitals or smaller institutions that serve predominantly underrepresented patients. They're able to develop interventions to address the needs of their population. However, in larger institutions with fewer underrepresented patients, how do we get leadership, I say change their hearts and minds, to prioritize interventions that address the needs of underrepresented minorities and disparities specifically, and allocate resources to address those?
Yeah, that's a great question. It's a hard one. The thing that comes to mind just off the top of my head while other people are thinking and maybe can answer better than me is that, decisions about adoption and implementation, even though we often talk about context and contextual influences and organizational structure and things like that, the ways that culture is changed is through actions of individuals. And sometimes the problem seems so big and difficult to understand that those who are in charge of, or who have the power to make changes in the organization, to make reducing disparities a priority, for example, don't really know what to do, don't really know where to start. And so as a planner that is trying to develop strategies to increase attention to and implementation of interventions that could address disparities, one of the first steps is to understand who are the key players and what they have to do. And then thinking about what influences or would influence or could influence their predisposition to do something. Sometimes simply laying out the steps, particularly if they're not that complicated, about the implementation of an already existing evidence-based intervention, making it reachable for them and tying it to the core values of the institution, sometimes that's enough to make a change. But I also realize that many times it's not that easy and you need multiple kind of strategies to make that kind of change.
Dr. Adsul?
Yeah, I'm very fortunate to be here at University of New Mexico with Nina Wallerstein. And this is sort of a question that we've been trying to answer for the last 3 years in some of our work, because what is happening in CBPR work is that we have the principles, we have these ideas, but when it comes to materializing these ideas, having communities be on the table in these institutions that have historical realities in our communities, right? There's a lot of challenges. There are a lot of administrative barriers. There's a lot of financial barriers in making this engagement operationalize in real life as a research community academic partnership. And so some of the work that we've been doing is actually turning our eyes back into our institutions and saying, what are some of those factors within our institutions? And Nina always says this, right? She always says a scholar should have an advocacy bone as well. So how do we become better advocates as researchers in our own institutions to start thinking about these processes and structures that can either facilitate these engagement activities, these partnerships, or not? And how do we carefully examine and start changing some of those structures within our own institutions? So we, as researchers, have this dual responsibility, not to our communities and partners, but also to our own institutions and improving them to be better. So we're doing some science around it. So stay tuned for some of the work coming out in this space as well.
So we, yeah, go ahead, Anna, and then we have one person who has raised his hand. Yeah.
I would just say the more that I hang out in this space, the more I think, implementation science, healthcare is political and economic. Yeah. And so the way to go about leadership is to have a business case. There's no other way around. You need to find your champion, and you need to have data, and you need to have a business plan. And then embedded in that is what Maria and Prajakta mentioned, right? In terms of hence the solution is, this is the evidence-based intervention. We need to be a little bit more thoughtful, I think, in our field, that implementation science political is economical. And, if we are to address equity, that's a conversation that we need to have, I think.
Yeah, that's well said. We have 5 more minutes, and we'll take perhaps 1 or 2 more questions. Cesar, do you want to unmute yourself and ask your question?
Yes, thank you, Dr. Vijay. Thank you all. It's been incredible to listen to your presentations. It actually gives me a lot of hope in the implementation sciences, which I'm very, very new to. But I've been thinking for a while on how to bring a sociological concept developed by Bourdieu, the habitus. So habitus is this structurized structure and this structurizing structure. So as we are with this really interesting question on how to change hearts and minds, how to actually. So I've been trying to think how habitus can contribute to be this, as Bourdieu said it, this bridge between agency and the structure. It's the way of the habitual way that individuals behave and do about their days that ultimately impact the structural ways also, no, that end up affecting individuals then. So this is something I just wanted to put out there because I really find fascinating that I'm listening, critical race theories and other perspectives that are being complementing implementation sciences and all these fascinating knowledge that is already there, but by bringing different concepts and different perspectives and so can contribute to that. So anyway, I was just thinking on how habitus might be an interesting way of addressing all these, at least to understand, because I think we have very well identified in many of the inequity aspects, the what's and the like we know what is those barriers, but we don't know the whys and the how they build themselves and how they preserve themselves. So trying to understand on this could also help us to move this a little forward.
Thank you, Cesar. We really appreciate your comment. I think I can see everybody sort of nodding. If one of you want to add, any comments related to that, I think this should wrap up our conversation. So Maria, I see you have unmuted. Would you like to say something?
Yeah, just thank you, Cesar. And I think that, and this is something that we've talked about. I think that our ability to look to other disciplines, like you gave a great example of a concept within sociology, where we can see how it applies and how this concept can make us think about overcoming some of the wicked problems in health equity. And I think that our ability as a field, and I'm talking about the field of implementation science, to look back as well as to look forward in terms of what we've learned, the theories, the other disciplines. I think that that's going to determine whether or not we're successful in making an impact on health equity. So thank you so much for bringing that up.
Those are really great recommendations and reflections, Maria and Anna and Prajakta. I'm almost sad to see that our 2 hours are up. We had a fantastic conversation, and I'm sure you are also seeing all of the really great feedback we're getting from people who have attended and stayed with us for these 2 hours. This is also the last of our seminar series this fall, and while we've had while it's ending, we've had 4 really thought-provoking seminars, and it heartens us to see the feedback you're giving us, which will make bring it back next fall, Maria. We've been doing this now. This is the 2nd year in a row. So I really, on behalf of Maria and me both, want to thank everybody who has attended and contributed to the discussions across these 4 seminars that we've had, and really enriched our thinking as well in the space that we all continue to work in. Feel free to reach out to us with any additional questions. And with that, I'll hand it off to Ricky if there are any last things that you need to add, Ricky.
That's it. Thank you so much, everyone. We put in the chat the link to the Institute social media in case you want to follow us to stay up to date on when their future seminar is planned. And this seminar recording, along with all the others, will be posted on our website, but we'll be sending all that out as well, so you have the direct links. Thank you, panelists. Thank you, everybody, so much.
Thank you so much for everything.
Bye, everybody.
Bye, everyone.
Bye.